So welcome back to PCM4U channel. We are very happy to have you, Aslaug Helland, professor in lung oncology and PI of the IMPRESS Norway clinical trial.
Happy to be here, yeah.
Thanks a lot. Oslo, could you tell us a little bit about the precision medicine program in Norway and how could you explain it for patients?
So in Norway we screen all the patients with the same diagnostics. So all eligible patients can have the same test. And of course we have to explain to patients that we find treatment maybe for 1/3 of them, whereas the rest of the patients then return to standard treatment and follow up. But most patients think that this is a real benefit, that we now try our best. We do everything we can to find a new treatment option for the patients, so that even though we don't find anything, the patient get closure and are happy about that we tried at least. Yeah. So that's a general feeling that we get feedback on.
So clearly you see many patients and you explain with your colleagues molecular testing. So could you give us an example of an explanation for patients?
Yes, yeah. So some tumors have what we call driver mutations in the tumor cells. And that's a genetic alteration or a change in the tumor cell that makes the cell divide endlessly, so that the tumor grows and spread to other organs. And that's of course, if we find this driver mutation or alteration, then we can try to find treatment targeting that alteration. Some tumors have this kind of alteration, and there are existing drugs that target it, but other tumors don't have that kind of alteration as far as we know today. They might have very many mutations, but we can't really pinpoint which one is important. And then it's difficult to find the right treatment.
So this molecular screening, do you do it on archive tissue of the patient, or does it require a new sample?
So I would say that the best is to have a new sample, but generally that's hard to get. So we use an old biopsy. Most patients have some archival tumor tissue from beforehand at the hospital, so we can use that for the diagnostics. And in IMPRESS Norway we also do analysis in blood. So we have this kind of circulating tumor DNA, rests of dead tumor cells or parts of the DNA, and we can analyze that as well. So that's both ways can lead to treatment options in IMPRESS Norway.
Okay, that's very interesting. And I'm sure many patients would prefer liquid biopsy, so a blood sample, than a new biopsy. So could you tell us, and how do you explain the frequency of positive results for a blood sample versus a tumor?
So that's some of the things that we are investigating right now. So we have now included 500 patients where we have both the tumor and the blood, and we will compare. Some patients we find something in the blood but not in the tumor tissue, and many times we find it in the tumor and not in the blood. So we need to understand more about what the use can be, because of course we don't want to do the blood if we don't find what we want to find. So that's important that we know that it's really high quality data that comes from the blood sample analysis.
Yeah, from what I've seen, as you said, it's complementary analysis.
Yeah.
So it can improve the orientation of patient to treatment in terms of frequency and chance to have a new treatment.
Yeah.
Based on such analysis, what are the type of treatments that you could propose to a patient when a result is positive, let's say?
Yeah, so right now we have 23 different drugs in Impress Norway. These are drugs that generally are given for free from the pharma companies that we collaborate with. And we have different kinds of drugs, like we have immunotherapy, we have antibodies, we have small tyrosines, it's small drugs called tyrosine kinase inhibitors, which target the mutations in the tumor cells. So we have several different types of drugs so that we can sort of attack different kinds of tumor cells.
And so for some patients it does work, meaning it controls the tumor or it decreases the size of the tumor.
Yeah.
For some it does not work because it's not 100% success.
Yeah.
So I'm sure it depends on the drugs, the treatments, but what is your general explanation in what a patient could expect when starting a treatment based on a molecular alteration?
Yeah, so these patients have received all standard treatment. They have kind of no standard options left. So they are informed that it might help them, but it might not. And what we see from the results that we have so far, we have a clinical benefit in like 45% of the patients. And some of them, we have some few patients where all the tumors have vanished. We have some patients where it have shrinked significantly. And we have quite a lot of patients where it stabilizes. It's the same size. And then, of course, we have some patients where it doesn't work at all, where the tumor grows. And we have some patients where the patients stop treatment due to side effects. Which, of course, there's side effects with everything, and some patients are quite sick, so...
yeah, it needs monitoring,
yeah.
And it's within a clinical trial.
Yeah.
So those drugs, so they are monitoring based on the clinical trial, I guess.
Yeah. So we collect all the data, and then we can learn from every patient how to treat the next patient, right?
There's another part of genetic testing which is germline mutations and can arise. It's not frequent. So how do you explain to the patient this possibility of a germline alteration and how can it impact the patient or the family?
Yeah, so that's important to discuss with the patients before they actually are included in Impress Norway. It's stated in the informed consent sheet, and the patient can choose to get this knowledge if we find anything that's heritable or not. And at the molecular tumor boards where all these results are discussed with different experts, there is also a geneticist, so that if we find a mutation that is often found in the germline, then we discuss that, and if the patient has said, yes, I want to know if we find anything, then we refer the patient to the medical geneticists so that they can have follow-up and maybe it impacts the family as well.
Yeah, so in practice, when a mutation is found that could be germline, if you have an example, what is the impact for the patient or the family?
So it might be that we find the BRCA1 mutation, for instance, and we find that we suspect that it's germline. Then if the patient can have consented, then we can refer that patient, and the patient talks to a medical geneticist and they take a blood sample where they can then analyze germline only. And of course, if the patient has a germline BRCA mutation, then that might have impact if the patient has children or sisters or brothers, you know. So it's important that this is taken care of in the protocol.
Okay, and it could save some relatives for a risk of a cancer based on their risk and their monitoring. So
then if the family members have the same mutation, they can be followed tightly.
Yeah.
And if they develop cancer, it will be discovered early. That's the aim.
So many impacts of molecular testing in oncology.
Yeah.
And that's very impressive. The Impress trial, because it's open to every patient
Yeah.
in the country. So many thanks for your clear explanations.
Thank you.
And see you soon.
Yeah, see you.